Well, hello everyone. Today we will see about the screening tests. So, which is Unit 9. So, in this study we will cover about screening tests and diagnostic tests. So, this is an important chapter. So this is a lecture outline, this is objective, you can see that. Now we are starting about screening in disease control. Screening is a presumptive identification of unrecognized diseases by application of rapid tests or examinations or procedures. So it's the ability of identification of unrecognized diseases by application of tests is called screening. Screening test is a search for unrecognized disease or defect by means of rapidly applying tests, examinations and procedures in apparently healthy individuals. This is very important concept, in apparently healthy individuals. So if it is in apparently finding unrecognized disease in apparently healthy individual is screening, but in ill individual is diagnostic. Ill individual is a diagnostic test. Okay, diagnostic. So if it is in apparently healthy is screening test, in ill or diseased individuals is called diagnostic tests. Detecting disease or risk factors in asymptomatic individuals, or symptomatic means almost apparently healthy, so this is known as screening. The examination of asymptomatic people in order to classify them as likely or unlikely to have disease of interest. So diagnosis is not equal to screening. Screening and diagnosis not similar. So screening is in healthy individual, apparently healthy. Diagnosis is in ill individuals. So why might we screen? So why we make screening, or what is the aim of screening, is all these concepts. The first one is that we screen to reduce the morbidity and mortality of our population or the population through early detection and treatment. So if the asymptomatic individuals early detected, they will get early treatment, so we can prevent morbidity, mortality. Then to protect the general public, so if they are detected, so that is hidden transmission of this asymptomatic individual will be minimized. To make the identification of the case in epidemiological studies, yes, for epidemiological research, for epidemiological studies, to prevent or delay occurrence of disease or improve its prognosis. So one, it's important to prevent the occurrence of disease by applying intervention on asymptomatic or subclinical stage, or by applying intervention to delay the occurrence of disease, or since it is detected, to improve its prognosis of the disease. So the other is to prevent transmission of disease, to prevent further disease, complication, to improve quality of life, to alter the natural course of disease for better outcome, to select the individuals usually for employment. We will make screening. For instance, for military driving license, it will be checked to determine frequency and natural history of disease condition. This is for research purpose. While we are doing research by X-ray, cytology, BP, serology tests, all these are the aim of screening. So screening is only useful for diseases which can be detected in their early preclinical stage or subclinical stage, and for which early treatment significantly improves the outcome. So to make screening, it should be there should be treatment. It should be in preclinical stage or in subclinical stage. That means it should not be developed signs symptoms. That means clinical stage. So this is an important thing. Screening can also be useful for communicable disease control, such as trachoma, schistosomiasis or TB, for which early treatment helps to prevent transmission. So what is the difference between diagnostic and screening test? That's what we have seen. So diagnostic test is performed in person with specific sign and symptoms. That means that in ill person or disease person. That means diagnostic test is happened on the clinical stage, on the natural state of disease. The other is screening test. Screening test is performed in apparently healthy individual. That means in the subclinical stage or preclinical stage. For example, blood sugar test in someone that is healthy would be screening test, and the same test in someone with symptoms of diabetes would be diagnostic test. Diagnostic because their symptom. So we will say diagnostic test. So the difference between screening and diagnostic tests. So screening is asymptomatic. So will be done in asymptomatic individuals. Diagnostic is suggestive clinical picture, will be done in those with sign symptoms. Screening will be made for larger population, and diagnostic will be done for single subject. Screening may be less accurate, and diagnostic is more accurate. There is not conclusive, this is conclusive. This is less expensive, this is more expensive. And also screening is not basic for treatment. That is, diagnostic test is intended for treatment, to order the treatment. So mostly in clinic, that is laboratory result which is sent for the single patient is diagnostic test. But in general population, that is done is screening. So natural state of disease and time of screening. So time of screening according to natural state of disease in the stage of subclinical disease or preclinical disease. So screening is done, meaning the best time for screening is at this stage, subclinical disease stage. Disease stage before diseases appear, before signs symptoms appear. So the other is type of screening. We do have 4 types of screening: the mass or population screening, multiple or multi-phase screening, case findings or opportunistic screening, and targeted screening, or we can say selective screening. So we can say 4 types of screening. Screening should be population based or single based. Screening should be single phase or multiple phase, can be single phase or multiple phase, can be at single level or at population level. So types of screening, the first one is mass or population screening. This is offered to all irrespective of the particular risk factors. Without regard to particular risk factors, all population in that area will be screened. So this is known as population screening. For instance, if there is something is suspected in one town, all population found in that town will be screened. This is population screening. The other is multiple or multi-phase screening. The purpose of 2 or more screening tests in combination to a larger number of people at one time. So this case, one or more than 2 types of screening tests will be applied one after the other or in parallel. So this is known as multi-phase screening. So we can divide into 2, parallel or series tests. Parallel testing means applying 2 screening tests and positive result on either test is sufficient to be labeled as positive, meaning there is 2 screening tests. From the 2, the one is a report positive, we will say positive. This is known as breast cancer screening. Series testing is applying 2 screening tests and both must be positive in order to prompt action. But series means one after the other. So 2 screening tests and both must be positive in order to prompt action, meaning the first should be positive and the second should be the second screening should report positive result, the second one positive to say positive. So this is known as series testing. This is done for HIV testing and syphilis. So parallel means in the simultaneously, series means one after the other. So this is multi-phase screening or multiple screening. The third one is that case finding or opportunistic screening. It is restricted to patients who consult health professionals for some other purpose. Example, sexual transmitted screening in OPD. For instance, this is mostly done, but it is limited for those individuals who seek for treatment or go to health professionals. For instance, if you want to find a STD in the population, so the health professional, when we are treating his patients, simultaneously he will find the case for a STD. This is known as opportunistic means. As opportunistic means using the chance in the health professional or case finding. So for instance, measles is important to be screened, so measles will be screened while we are working in their OPD. So this type of screening is known as case finding or opportunity screening. The last type of screening is targeted screening, or we can say selective screening. This is known as high risk screening or selective screening. In this case, nutritional screening is done for children and pregnant mother. Screening of people with selective exposure. So by selective exposure, it will be screened. Selective, for instance, nutrition. Based on nutrition, children or pregnant mother will be screened. Based on some exposure, they will be screened. So this is known as selective screening based on risk factor. So we have seen 4 types of screening. So now modified Wilson criteria for introducing screening program. So by the way, to run one screening program, screening program should pass a number of steps. So according to Wilson's criteria, we have it should pass 4 criteria. So one, about Wilson criteria, to start one screening program, it should be observed the disease condition, the test, and the treatment, finally the program. So program, from 4, the most important is the disease condition, is the test criteria, but according to Wilson there is 4 criteria. So let us see this one. The disease condition, important health condition. It should to be screened, to be start screening for that disease, it should be important health condition, important health problem. Maybe that problem is prevalent or serious, has early stage, that means subclinical stage. Should be just like this. The other is high prevalence at asymptomatic or subclinical stage. High prevalence, adequately understood natural history. The disease natural history is well known. So based on this condition criteria, you should fulfill this. And based on the test, is the test to screen that disease should be simple, precise, validated, and the test should be acceptable to the population. The population which that screening will be applied will accept that screening test. The other is agreed to diagnostic test, meaning the test which is gain is almost similar and related with the test or the finding found by diagnostic test. So meaning the diagnostic test is a gold standard though. So the screening test should compare the finding of screening test should be similar with the findings of diagnostic test. So the test should be available, adequate, effective, acceptable. So it should be sensitive, specific, reliable, simple, cheap, and safe. So the test to be applied should fulfill all these criteria. The third one is treatment. When we see the treatment should be effective treatment. The treatment is easily available, adequate, acceptable, and also it should be effective treatment. And evidence-based policies on whom to treat. So there is evidence-based policy on that. The other is the program. The program of screening should be acceptable to public and professionals. So both the population and the health professional should accept that screening program. So the screening program, benefits of the screening program should outweigh the risks. That means benefit should greater than risks. Meaning the benefits comes due to program should be greater than the risks that program will lead. The other is the program facilities and staff available. Facilities and staff available. So the facilities, constructions and staffs or health professionals to run that program should be available. There should be available staffs, there should be available facilities. The other is overall cost should be assessed. Yield. Overall cost should be assessed. If the cost is assessed, whether that program is beneficial or not should be will be verified. So overall cost should be assessed is the 4. Now this is the 4 criteria, is a very important criteria which is applied by most of the time, and this is known as Wilson criteria, but there is also WHO criteria. For your information and knowledge, we are adding this WHO criteria. The criteria for establishing a screening program should fulfill the following almost 10 criteria. So this 10 criteria, from these 10 criteria, the first one is that the problem to be detected or the disease should be important enough to be worth detecting. There should be an acceptable intervention, which is effective intervention or effective treatment should be prevalent. The intervention should be available and feasible. There should be recognizable latent or early asymptomatic stage, which is long. There should be suitable test. The test should be acceptable to the population to be tested. The natural history of the condition should be adequately understood. There should be an agreed policy regarding when intervention is appropriate. The cost of detecting the problem and its remedy should be reasonable. The reasoning program should be, the screening program should be ongoing and not one time effort, Almost it's similar to Wilson's criteria, which is the criteria which we have seen before. So this is 10 WHO criteria. So if this criteria is fulfilled, we can start a screening program for one disease or for one disease condition. So this is all. The other is accuracy of screening test. How to know about that screening test is accurate or not. Test should be unbiased, precise, be able to determine the disease status of an individual without error. So if determined without error, we say accuracy. Accuracy is the ability of one's test to correctly classify individuals according to the disease status, those of without disease and those of with disease. This is known as accuracy. Accuracy will contain both validity and reliability. So the measures of accuracy of screening test, accuracy includes validity and reliability. Reliability means, in another word, precision. So it should to say accurate, it should be valid and reliable. So validity means application of screening test. Application of a screening test is to identify correctly individuals who do and do not have preclinical disease. So validity means the ability of the test to identify correctly those who have disease and those who do not have disease. So those who have clinical disease should test positive, those who do not have disease should test negative. So it is expressed by sensitivity and specificity, meaning validity can be divided into two, sensitivity and specificity. So the other type of accuracy is reliability or precision. Reliability is the ability of a test to come up with similar values upon repeated measurements in similar occasions. Meaning, if one person measures one thing in 2 times, in 2 times or more than 2 times, the value you have got from that measurement should be similar. So the value what we have got from repeated measurement should be similar. This is known as reliability or repeatability or precision. Now when we are comparing reliability and validity, this one is neither valid nor reliable. So this is target area. So if you have got the target area, we can say valid. But this point or this finding will be approximate each other, will be close to each other, we can say reliable. So they are far apart, so they are not found on this area, so they are neither valid nor reliable. This is reliable but not valid. Reliable, they are close to each other but not found here, so not valid. This is fairly valid but not reliable. This is almost close to this area. This is valid but not reliable. But this one is both valid and reliable. They are found on this target area and true. They are true or valid, so they are close to each other. It is reliable. So what we have found is this. What we have need is this one. So by 2x2 contingency table, this is called gold standard. So this is diseased, non-diseased, or we can say positive, negative. This is screening test, which is positive, negative. So screening test is compared with gold standard, and if it is true or approximate, will support this screening test. So this is A, or we can say true positive. This is B, we can say false positive. If the disease individual, which is found positive in the screening test, which is true positive, C is true false negative, and D is true negative. So A plus B is this one total, C plus D is this one total, A plus C is this one, B plus D is this one. This one is overall total. So this is a very important thing. So the number of individuals for whom the screening test is positive and the individual accurately has the disease. So the individual have disease. So if the test saying positive, we can say true positive. This one we can say true positive. Have disease, but the test says positive, so we can say true positive. False positive means the number for whom screening test is positive, but the individual do not have disease. The individual do not have disease, but if the test says positive, we can say false positive. This is false positive. The individual is non-diseased, but the test says positive. This is known as false positive. The other is true negative. The screening test says negative, but the individual does not have disease. The individual does not have disease, but the screening also says negative. This is known as true negative. So this is true negative. The individual have no disease, but the test also says negative. There is no disease. So this is nice. True negative. So the other is false negative. The screening says negative, but the individual does have. The individual is with disease, but the screening says negative. This is known as false negative. False negative means this one. The individual have disease, but the test says negative, no disease. So this is known as false negative. So measures of validity of test. The validity of screening test is how well the given screening test reflects another test of known greater accuracy. It assumes that there is gold standard to compare with. Meaning validity means how will be similar with the gold standard, or how be similar with diagnostic test. That means if screening test is similar, the finding of screening test is similar with diagnostic test, which is gold standard, we can say valid. So now in this chapter we will see validity, predictive value, reliability, and yield. After this, so having this concept, now how we calculate so measures of validity divided into sensitivity and specificity. What is sensitivity? The ability of the test to recognize people with disease. So sensitivity means identifying those people with disease. It describes its ability to correctly identify people who have the character that is being measured. So sensitivity means the ability of the test to identify those with disease. So to calculate sensitivity, we will use this formula. Sensitivity is equal to true positive over true positive plus false negative times 100. So true positive plus false negative. So this is true positive over true positive plus false negative is called sensitivity. False negative is called sensitivity times by 100. So sensitive plus false negative is equal to 100%. So the test with high sensitivity will have few false negatives. So if it is high sensitivity, it will say always this have this. So the calculation for sensitivity is just like this. The other is the specificity test. The ability of the test to recognize people without disease. The ability of the test to recognize people without disease is called specificity. Sensitivity means recognize people with disease. Specificity means recognize people without disease. So the proportion of people who do not have condition who are correctly classified as non-cases. So specificity means true negative over true negative plus false positive times by 100. So this is true negative over true negative means D over D or true negative plus false positive. This is called false positive, meaning D over D plus P times by 100. So so this is sensitivity and specificity. So specificity plus false positive is 100%. So the test with high specificity will have few false positives. So ideally screen test is expected to be 100% sensitive, 100% specific. In practice this does not occur. Rather, sensitivity and specificity are inversely related. That means if you get more sensitive, if the one test is more sensitive, specificity will be decreased. If it is more specific, sensitivity will be decreases. So the value depend on cutoff point. Can gain one at expense of the other. That means if you get sensitivity, you will lose specificity. If you get sensitivity by making cutoff point. So the optimal cutoff point depends on the relative costs of false positives and false negatives. So the validity is also affected by host factor like stage of condition. Concomitant presence of other conditions will affect it. Not affected by prevalence if severity is constant. So not affected by prevalence if severity is constant, meaning validity is not affected by prevalence. But predictive value is affected by prevalence. So predictive value are affected by the prevalence, the specificity and sensitivity, but validity is not affected by prevalence. So and also validity is not directly useful for health professionals, but predictive value does. There has a direct importance. So having this concept, now we are shifting about the predictive value. By the way, predictive value divided into two, positive predictive value and negative predictive value. By the way, predictive value means the ability of the test result to predict the presence or absence of disease. So now we will come back. So this is so predictive value divided into two, positive predictive value and negative predictive value. When we see positive predictive value, the probability of a person having preclinical disease when a test is positive. The test is positive. So the probability of person having a disease, preclinical disease, when the test is positive. So when the test is positive, that person have a disease, preclinical disease. So it shows how the test is accurate. The other, it is defined as the proportion of people with condition or clinical disease among all those who have received positive test result. So the proportion of people with the condition among all those who received a positive test result. So meaning among those who have got positive test result, how many of them are really have a preclinical disease. So predictive value, positive predictive value is equal to, or predictive value, positive predictive value is calculated by the true positive over true positive plus false positive. So true positive over true positive plus false positive times by 100 is, and it is a formula for formula to get predictive value, positive predictive value, meaning this true positive over true positive plus false positive means true positive or A over true positive over A plus false positive. So A over A plus B, A over A plus B. So meaning at the same time D over D plus C is known as predictive value negative. So we will see. So this is known as positive predictive value. So when we see negative predictive value, true negative over true negative plus false negative. This means that C over C plus D over C plus D. Yeah, D, true negative means D over D plus C, D false negative, D over D plus C. So true negative over true negative plus false negative times 100 means D over D plus C. So negative predictive value means the probability of a person not having a preclinical disease when the test is negative. So this means that when the test is says negative, really the patient there is no clinical disease. So it is a proportion of people without a condition among all those who received a negative test. Among those with negative test result, how many of them are did not have the disease? So predictive value negative or negative predictive value is true negative over true negative plus false negative times 100. So predictive value depends on one, sensitivity, two is specificity, the other is true prevalence of disease in that community. So please don't forget that predictive value depends on validity and prevalence, whereas validity is not dependent on prevalence. Positive predictive value is influenced by test specificity and true prevalence of the disease, whereas negative predictive value is influenced by test sensitivity and true prevalence of the disease, meaning prevalence will affect it plus specificity and sensitivity will affect it. Immediately useful to clinician. Validity is not directly or immediately useful for clinician, whereas predictive value is immediately useful for clinicians or health professionals. They tell us about the population and thus the patient depend upon the prevalence of disease. So test must be calibrated for clinical setting. So this is about predictive value, prevalence of disease and predictive value. Predictive value positive or positive predictive value is directly related to the prevalence of the disease in the community. the prevalence of the disease in the community. So this is prevalence, this is positive predictive value, so it is directly related or directly proportional. Negative predictive value is inversely related to, indirectly related to the prevalence of the disease in the community. So this is positive, this is negative predictive value, this is prevalence, so they are indirectly related. This is directly related, don't forget this one. So this is as a revision or summary. Sensitivity means sensitivity is equal to A over A plus C. A over A plus C, true positive over true positive plus false negative. So true positive over true positive plus false negative. This one is the same. So times by 100. Proportion of true positive with disease in another meaning. Specificity is equal to D over D plus B, meaning true negative over true negative plus false positive times by 100. Proportion of true negative is identified. Predictive value, positive predictive value is equal to positive predicted test or value is equal to A over A plus B times 100. A over A plus B times 100. So this is the other is meaning proportion of screening test positive who are truly positive. Proportion of screening test positive who are truly positive. Negative predictive value is equal to negative predictive value is equal to D over D plus C, meaning D over D plus C means true negative over true negative plus false negative times by 100, meaning proportion of screening test negative who are truly negative. This is our summary. Now we are passing yield. Yield means cost, analyzing overall cost of the program. So the number of cases of the condition detected by the screening test in relation to the total number of persons screening. So how many of cases will be get, how many of cases will be found among those total people of screening. So this is judged by yield. So yield is equal to true positive over true negative plus true positive plus false negative plus false positive. So among all populations which is screened, how many of are true positive, how many are true positive times by 100. This is affected by sensitivity. Yield is affected by sensitivity, prevalence, number of tests, frequency of screening, participation of people in the screening, and follow-up. So yield means persons with disease detected by the test over total screening times by 100. This means this one. This one is an interpreted one. So this one. So yield, cost of screening program means yield. What is the anticipated outcome in relation to resources expended? How many people with disease of interest are detected by the program out of all screened? So this measures the cost effectiveness of the screening program, which is known as yield. So overall cost assuming is related with yield. So it's very important whether this screening is feasible or not. So this is yield. So calculating yield is very important to know whether that screening program is effective or not, or beneficial or not. So strategies to increase yield of test: select diseases with high prevalence of clinical stage. So this is very important. Yield, to increase yield, to increase detection rate. Target high risk group for screening program. Select a test with high validity. High validity, that means with good sensitivity and specific test. So this is very important to increase yield. So yield screening test, by the way, this is an example for to try that. This is gold standard reference test, positive or negative. Positive means diseased, non-diseased. This is screening test, which is positive and negative, meaning exposed, non-exposed. So this is given values. So this is total value. So I need to calculate sensitivity, specificity, true predictive value, positive predictive value, negative predictive value for yield 5. So please calculate based on this example. So when we calculate sensitivity, it will be 15, this much number to this much number, it will be 75.2. so this one is divided for this one, this one is divided for this one, it will be sensitivity, and also this one, so this one is divided by this one, it will be specificity, it will be 58.5. so positive predictive value is this one divided by this one times by 100, and negative predictive value is this one divided by this one. So final yield means this is yield, so 15.55 or 1555 divided by 4451 is yield. So multiplied by 100. So this is all how to calculate it, the 5 types which we have seen. So this is an important example, so try to memorize the formula to calculate this one if you given just like this example. So please try to understand it. So the first type of objective is validity. We have seen validity like specificity and sensitivity. The second type is reliability. So the ability of the test give consistent result, similar result performed more than one time on the same individual under similar conditions is called reliability or precision. Affected by variation in method, observer, characters to be measured. So reliability having many categories like inter-observer variability, intra-observer variability. So please read more about the reliability, but this is the second section. So when we are passing on the other method, potential source of bias in the screening program. The first is self-selection bias or voluntary bias. The other is lead time. By the way, lead time bias and length time bias is the second most commonly known in the screening program. Biases in the screening program. So now the other is criteria for successful screening test. Screening test should be screening test facilitators should facilitate for diagnosis and appropriate treatment should be available for positive subject. So meaning to do screening test there should be diagnosis and appropriate treatment for those positive subjects, meaning those screened and their value is positive, there should shift to the appropriate diagnosis and treatment, otherwise it should not be unethical. So ethically not acceptable to offer screening without available management. So do not treat them, we are not screening them. So to screen them we should available the management and all diagnostic facilities. So the other is ethical issues in the screening program. Issues of informed consent is issued of informed consent in the screening. So to screen individuals we should take informed consent of individuals, those who will be screened. Screening test accuracy, validity plus reliability. So screening test should accurate to minimize false positive and to minimize false negative. So because having some consequences, telling the finding of test to those people, those who are not So because screening test should be accurate, because false positive test may cause unnecessarily anxiety. So if you, for instance, if you are telling non-HIV individuals that he has an HIV, so he will be more anxiety. Maybe he will kill himself, or he will too much obsessed. So this is another problem. The other is false negative test may result in loss of life. For instance, that patient has disease, but you are telling him due to false negative of the test, you are telling him he has not the disease. So one, since it is not early screened and early identified and treated, he will be die. The second, he will be also since he is not free, since he has been told free, he will be transmit that infection to the total population. So accuracy of the test is very important. So what is the risk of screening? Risk of screening: true positive, false negative. So true positive, it is labeling effect, but the problem is false positive and false negative. False positive will create telling that person having disease really, but he hasn't disease. So it will create for him an anxiety, fear from future tests, and monetary expenses. But for negative one, telling those with disease really those who have not disease, this means they have disease, but we are telling they have not disease based on screening test. So this will delay the early diagnosis, delay intervention, delay early treatment, and so that person will develop complication, sequelae, or death. So this is a risk of screening. So type 1 error, meaning false positive. False positive means telling the male individual as he is pregnant. But he will not be pregnant in fact, but telling them that's because of the instrument problem. False negative means it's type 2 error, meaning telling that this pregnant female as she is not pregnant. This is related with the accuracy of the test. So this is all about chapter 9, or screening test. So this is all about. So thank you very much for watching this video, and don't forget to subscribe this channel to get the other courses, videos, and chapters and sections. Don't forget that. So to subscribe to get the next videos. Have a nice time, and bye bye.